Good afternoon, everybody. Today is June 18th. This is the Oregon Health Authority team providing your weekly webinar, of course, alternating with the Project Echo sessions. So today, this is Dana Harganani, Chief Medical Officer for the Oregon Health Authority, and I am joined by colleagues. I'll have them introduce themselves.
Hi, this is Tom Jean, Deputy Health Officer for the Public Health Division.
I'm Arielle Smith. I'm one of the Senior Health Advisors, and I'm the Medical Director for the Health Evidence Review Commission.
So, as you are probably well aware, there is a lot happening right now. We are going to try to pack in a lot of information today to give you some timely updates. I will tell you we've added more detail to our epidemiology update. We know some of this is available on our weekly and daily updates, but we wanted to provide some context here for increasing cases and what's going on in the state with regards to COVID-19. So we will spend some extra time on that. We're going to share some brief updates on some of the work we are doing to address the disproportionate impacts of COVID-19 and supporting the populations who are being affected. You may know that the governor is just finishing up, I believe, her press conference related to reopening. We'll give you a bit of update what's happening there if you were not able to listen in. We're going to briefly share about some work on long-term care facility testing and then dive in a little bit more detail with Dr. Jean about thinking about how to interpret test results. We hope that will be useful to you today. We'll give a little bit of updates from what's happening in the FDA or in the COVID literature and FDA update, as well as answer some of your clinical questions that we've been receiving. So we will get started. First, with some of the traditional data that we share with you. As of yesterday counts, we have a total now of 6,007 positive COVID-19 cases in our state. A total of 183 deaths as of yesterday. And you can see a lot more tests that have been completed since the start of this, now over 178,000. As we're going to speak to today, we've been spending a lot of our attention on multiple outbreaks happening in the state and increasing community spread, and we'll speak to all of that as we're working through these updates today. A couple other points of data. These come from our weekly update and our testing update. So as of June 14th, Sunday, in the last week, we had 889 new cases. This, of course, has been highlighted in the media and reported by us in our daily reports. And noteworthy so, this is a 44% increase in new cases as reported from the week prior. We are also doing a lot more testing. We've done over 20,000 total tests per week over the last 2 weeks. And as you know, we've been building up over time, but this really marks a new height of testing that we've been able to do. Certainly some of the cases we're capturing are related to that increase in testing. We've also been monitoring the percent positive of those tests. We didn't share the graph here, but as you recall, I think about 4 to 6 weeks ago, we reported the low of our percent positive that reached 1.6% of all tests about that time. That has been slowly increasing. Based on the last week, we had a total of 3.1% positive tests. That data is through Sunday. Also sharing, we're keeping an eye on the percent of cases who have been hospitalized. This is data we collect through in-case investigation and reporting from hospitals. We've had a total of 899 or almost 900 individuals of those known 6,000 cases who've been ever hospitalized. That's about 15% of our tested positive cases. And of course, monitoring the severity currently based on our positive or known COVID patients, there's been a case fatality rate of 3.1%. That is certainly not representing those who were not tested, certainly early on with more mild disease or still not captured through our testing. So the total case fatality rate overall is much lower likely much lower, excuse me. I'm going to pass it now to Dr. Jean. We'll go through some of our graphs to give a look at what's happening right now.
Thanks. So yeah, this is our familiar epi curve, and it's looking a little different these days. we've seen, of course, a big increase in cases in the past couple of weeks, and as we'll talk about, some of those, or a big chunk of that, is related to large outbreaks, which have been in the news in several counties, and you know, it really does show we had a pretty steady plateau of cases for many weeks, and then a little bit of a decline, and then this recent increase. I would also highlight that hospitalizations remain quite low so far, even with the large increase in cases that we're seeing. On our website, we have some interactive or kind of a dashboard that has some different ways to look at data, and one of them is the case count by county. And you can see, just based on the shading here, that Union County is certainly far in the lead now with their outbreak. The outbreak tied to a church, and that is the largest outbreak to date in Oregon for COVID-19. Lincoln County on the coast also had an outbreak at a food packing facility, and so those are kind of the two highest county rates right now.
Just to share a little bit more information, there has been a lot of information shared already and discussed in the media about these outbreaks, but just wanted to hone in a little bit as you're looking at this map and noting the high case counts in Union and Lincoln counties. As Tom just outlined, these are two outbreaks, one again centered on linkage to a church in Union County, and the other to a workplace setting related to seafood packaging. These have been first for certain began with notable increased cases identified and or hospitalizations linked to these sites, and then broader community testing offered kind of en masse to these locations and connections to these outbreaks, which has both produced for us very large testing results from really starting over the weekend, for Union County over this weekend and Lincoln County the week prior. Those numbers are going to likely continue to grow as we do more testing in those areas, and then start to do further testing as we identify additional symptomatic people in the community or linked to the cases. As of 2 days ago, I believe the Union County totals were in the mid 200 range, and the Lincoln County totals were in a mid 150. I don't have the latest data. This has been a really significant effort happening in coordination with our state health agency and our local public health authorities to really lift and respond to these significant outbreaks. This includes information sharing with the community and affected populations and workers. It includes, of course, a very significant and robust attention around case investigation, and really building on resources, because the numbers of cases there, can quickly outweigh the capacity. And so the state has stepped in to support that. Neighboring county public health authorities and tribal public health authorities have stepped in to support these outbreak case investigations, and then case contact tracing. So really significant work happening there. In addition, of course, quickly assessing the additional wraparound and other social service supports that are needed by these communities, and ensuring that we're offering and connecting with local, culturally specific community organizations to support and ensure information is flowing in a way that is responsive to needs of all communities in both of these counties. So this is an ongoing area that we will continue to pay attention to and share updates. We are also ongoing addressing additional outbreaks, as we have listed in our weekly report, of outbreaks in other workplaces, as well as ongoing concerns and cases in long-term care facilities statewide. So all that information is shared on our weekly report. So back to Dr. Jean.
Yeah, thanks for adding that. So this is just another way to look at our cases according to the epidemiologic link, and wanted to highlight the yellow bars at the bottom, which are kind of the default categorization for a case, which is called sporadic. So that would just mean there's not a known link. And then the gray is an outbreak. So once cases are determined to be part of a known outbreak, then they would go in that category. Cluster is in the blue, and cluster is really kind of a holding pattern. If a cluster of cases in a space or time is noted, but they're not actually determined to be an outbreak yet, they would be there. And then the orange is household, so basically an outbreak within one household. So the most, week 23 and 24, and these are just kind of the epi weeks, they call them. So these are probably the most recent weeks for data here in June. And weeks 23 and 24, of course, there's a big increase in cases. And there's also an increase in the number of their outbreak tide. Week 24, we're probably going to see more of those end up being linked to outbreaks because the investigations are ongoing, because that just happened. So that would be the highlight there.
I'm going to pause. As of the last time we did this, we are able to see chat box questions. So I'm going to just pause and make a couple comments here. One, thank you for letting us know about the resolution. I do want to let you know that all of these graphs and slides we've showed with these visuals are directly from our weekly report and available online, where you'll be able to see more of the details. So that's at healthoregon.org/coronavirus. So we will try to give more attention to the resolution from the slides that we're sharing, but please do know all of this is available. There was a question about the case count, and I'm going to just go back to this by county. And the question was, is the COVID case count just for last week or since the start of the pandemic? And I believe the answer is since the start of the pandemic. And I'm getting a head nod from Dr. Jean. So yes, this is a cumulative case count based on our cumulative case count since our response and our first case identified in late February.
That's a good question. We should probably clarify that in the text for this figure. So.
Yeah, so we'll update it online too, but that is the answer to this. And one other question I think we can just pause briefly for, can you please help me understand why the daily numbers reported by OHA match the numbers on the epi curve, or how? I think maybe just to say something about that, and we can follow up if we're not answering the question. The epi curve, as we show it, looks at cases based on the day of symptom onset. Is that correct, Dr. Jean? I just want to confirm that. So we may be reporting new cases that come to our attention, of course, through positive tests. But when we do the case investigation, we identify closer to what the onset of symptoms are, and then that's reported on the epi curve by onset of symptom. Anything to add to that, Dr. Jean?
Well, I'm just noticing that we on the earlier slide we reported 6,007 positives, and this says 6,218, and I'm actually, that's probably just a lag in one of them. I'm not sure exactly why.
Oh, great. We will double check on that. That's a really important point. I will say that when we're reporting the positive test results, we also collect information on what we consider presumptive cases that aren't going to be captured in our positive test result cases, and I think that is probably the difference.
Yeah, good point. So the 6,007 would be the positive test results, and the discrepancy here would be that the presumptives who don't have a positive result but have a clear contact and the right symptoms, they are counted as presumptive cases, and they're included in the total here.
Great.
Thanks.
At our next slide, our next webinar, we'll try to differentiate those two for you, and we can bring back to how we identify presumptive cases. It's very much a small percent of our overall cases, but we can bring more clarity for that. Thank you for.
Presumptive aligns with the CDC's guidelines for what they call probable cases nationwide.
Great. Thanks for the questions.
So just very quickly, we've seen these before. Daily ED visits over time, dating back to January. Big decrease in March, and we've still seen this kind of steady but slow gradual uptick in total ED visits, still below baseline. And then interestingly, we are still seeing very low daily ED visits statewide for COVID-like illness. Part of the spike that we may have seen in March was what could have been related to influenza, but I think this also raises questions about the cases that we're seeing now. Maybe some of those are not as severe, and also workplace testing is going to mean many of those people who are tested did not go in through the ED. But this is still an important indicator, and I think it is reassuring that we're not seeing a steady uptick, at least not yet, in ED visits for COVID-like illness. This is cumulative risk factors for all of our cases as of June 14th, just highlighting that contact is probably the biggest risk factor, and clearly the biggest risk factor here. And then congregate living settings are also a big risk. And then in terms of risk of being an overall risk factor for severity as well, underlying conditions are pretty significant. So I don't think we need to belabor the point. And then direct patient care of those people who reported working in a healthcare setting, 76.7% of cases had direct patient care. So no change there, no significant change. Next slide is showing signs and symptoms, and no significant changes here either. Cough, headache, muscle aches, and then a total of 78% of those who did answer, were able to get the information, did report any symptoms. So about 11.8% asymptomatic.
I wanted to just pause here on that note too. This is data as of Sunday. And we've been receiving a lot of questions, particularly related to the Lincoln and Union County outbreaks, as well as others, about what proportion of these newly diagnosed cases are asymptomatic. I think we're going to keep a close eye on this top line. The number, or the percent of our cases who have had any symptoms has actually changed just so slightly over time. Right now, it's nearly known about 77%, as you see here, have had a symptom, and about 10% none, and then still a percent that we aren't able to get that information from. We're going to monitor this over time. I would, while there have been some reports, and certainly in our initial response to outbreaks, of a lot of people being asymptomatic, I think we actually gain more information during the case investigation process that will help this flush this information out. So I just wanted to note this data is a little lagging because we still have further case investigation work to show up here, but this is one of the areas that we're going to want to pay attention to help us. We certainly know, especially when you're thinking about a workplace outbreak and perhaps beyond that, there could be some disincentives for reporting symptoms as people's livelihoods are related to their work, their ongoing work. So we have a lot more information and certainly a lot of resources to support those individuals who are being impacted from having to step away from work as they or their family are impacted from COVID. So that's a really important area for us. But in terms of understanding the presence of asymptomatic cases, we're going to learn more over the next couple weeks, I believe.
Yeah, because this is cumulative, and because our guidelines, because of testing limitations, for a long time we're focused on symptomatic patients, and still are focused on people with symptoms. That is going to affect that proportion there. So this certainly doesn't mean that we could extrapolate this to all people who have COVID. This is the percentage who have symptoms, because many of those people without symptoms aren't being tested.
Great. Oh, so we just wanted to share a little bit more information. This slide here is a new graph that we've included in our weekly report. You will see that there's a lot of unknown data, particularly in these last couple weeks. And this is most certainly due to the large number of new cases and the ongoing case investigation to capture this information. But it's a different way to look at the disproportionate impact of communities impacted by COVID. So I think the notable trends here are that the Latinx community has had an increasing proportion of the cases over time. Again, noting here very significant unknowns over these last couple of weeks as we've expanded our outbreak case investigations. So this is an important thing that we are keeping a close eye on. We have looked at this in different ways. These are the tables here that you've been looking at with us over the last couple of months. Here you can see, again, the disproportionate impact of COVID-19 on the Hispanic or Latinx community, with a total of 34.8% of the total cases represented from that community. Fortunately, at this time, the case fatality appears to be much lower in the Latino population, and we were again keeping a close eye on all of this, alongside the severity that we're monitoring by race. So here again gives you a better understanding about the severity and rates across different racial and ethnic groups. We've shared this before. We continue to work heavily on improving our data collection around race, ethnicity, and beyond. You can see here that we don't have data currently on almost 13% of cases with regards to this data. We also have limitations with the way this data is collected. We do believe that the majority of people on this race table, based on the way questions are answered, for the other category, most of those are representative of the those identifying as Hispanic in the prior slide. So again, very important areas of our attention in our work with communities to address these disproportionate impacts, which we'll speak to a little bit more later. Just getting a different viewpoint again of what the impact is on severity of disease and what are we seeing in our hospitalizations. As you likely know, looking at hospitalization data currently is a lagging indicator of what's happening on severity. Hospitalization usually lags beyond, of course, exposure, then symptom onset, and then later hospitalization. But we have seen certainly uptrends in this over the last couple weeks. This is data just as of today. If you look at the known positive cases, we have been trending upwards with a total of 89 reported hospitalized COVID patients as of this morning. A little less than half are requiring ICU care and about a quarter requiring mechanical ventilation. This next slide helps you understand what those trends look like. Again, this is reported by hospitals to us and is looking at current daily hospitalized patients with COVID. And so you can see we are far from the peak that we were at earlier in the beginning of April, but a slow trend upward. I will note as we monitor our hospital capacity and work with our hospital partners, there's still certainly plenty hospital capacity at this time, but this is a concerning trend that we, of course, pay close attention to. One other thing, this is a different data source that we capture from our case investigations and reporting through hospitals to look at what is the length of stay. These are out of our cumulative cases who have required hospitalization in Oregon, and we just started reporting this on our weekly report. So this is still new information to me as I'm getting used to it, but I wanted to call this out to you. Of those who've required hospitalization, 164 of them at the time of this data pulled, we don't know how long their hospitalization has been. That may be because their discharge is still pending. Perhaps they're a newer case and they could still, we just have more information to gather there. But of those, we do have information on. You can see that the majority required a 1 to 4 day hospitalization. And then you can see moving down that we still have a significant number of hospitalized COVID patients who've required over 2 weeks hospital stay. So we're starting to get more data on this that I think is both helpful for all of us and particularly planning at our hospital capacity level. Okay, moving on from our EPI update, I did want to spend a few minutes talking about some of the work that our agency and partners have been doing to address some of the disproportionate impact of COVID-19 on various communities in our state. I think we've shared before, we recognize that we have significant more work to do to address the inequities of COVID impact and, of course, the underlying social and health inequities that have contributed to this. Some of the work we've been doing over these last couple of months and building upon is work both with our local public health authorities and our state response to work with community leaders, culturally specific community leaders, other community organizations, employers, and others to identify quickly the needs and act on the priorities from different communities across our state. Some of the priorities that we've heard from communities that we are working to address include things like improving how we collect race, ethnicity, language, and disability data to help us understand the impacts and address those. There's a significant amount of work happening to improve that. We are also actively building around supporting the financial needs of people, particularly those who are missing out on work or other supports through quarantine and isolation, housing needs, food and other resources. This isn't always the Oregon Health Authority. There are many other state agencies involved in the statewide emergency response and building out their resource and response in these areas. We've heard a lot around needs for improved access to testing for various communities of color and others. And we have been working both with local public health authorities across our state, as well as community organizations to provide community-based testing opportunities to improve that access. We certainly there's an ongoing and ever-growing need for culturally relevant messaging, linguistically accessible messaging around best practices, way to support families, how to reduce your risks and beyond, news updates on outbreaks. And we continue to work actively in our state to ensure things are updated quickly in multiple languages, and working with other consultants and contractors on developing culturally relevant messaging. And as we've shared with you before, we've been developing more information and dispersing it related to access to enrollment for CAWM, coverage, information on public charge and COVID testing, and trying to reduce where we can the fears about getting access to COVID treatment with regards to immigration status. And we've also been working to develop out funding opportunity and partnership with community-based organizations, which I'll share, but again, want to hone in on. We are hearing and understand loud and clear that we have much more work to do to address these disproportionate impacts. A little bit about the funding opportunity. I gave you the website down below. But the Oregon Health Authority and our partners really recognize that community-based organizations are central to the success of our work, and really particularly important to help us develop and implement the tactics and strategies that are most responsive to the needs of our diverse communities in the state. We have put forward a request for application a few weeks ago, asking for community-based organizations to apply to support all or some of the following areas of work. So the three kind of areas of focus in this request for applications include community engagement, education and outreach, contact tracing, social services, and wraparound supports. And community organizations can respond to the RFA for one or all of those types of supports that they'd like to help us with. Again, we're expecting a very large response based on the inquiries and the work we've done to co-create this opportunity, and really expect to have a lot of culturally specific and responsive CBOs on board to help us in our response that is more responsive to the needs of our diverse communities across the state. The application deadline is coming up quickly here on the 24th, and we're going to be working hard to turn those around quickly because we know the need is great and the desire is large to help in this response. So please take a look at further information if you are interested here, and we'll keep you posted as this work unfolds. All right, shifting gears a little bit, reopening, of course, has been a high topic on everybody's minds in the media, of course, and we've been monitoring and supporting the governor's office in looking at the data and public health indicators, as we've shared with you before. I expect that most people had seen this was a press news release by the governor's office yesterday, outlined some of the changes that she would be announcing at today's press conference. So if you want to go take a look at this news release, the link is at the bottom, or you can find it on the governor's webpage. But basically, this is what was announced both in this news release and the press conference today. In full transparency, I did not have a chance today to watch the press conference, so some of you hopefully were able to see it and may have even more up-to-date information than I. But the announcement was really focused on these three elements. Starting tomorrow, June 19th, the governor was allowing Marion, Polk, and Hood Rivers to move forward into phase 2. So again, releasing this pause that she had announced last week. and also allowing Multnomah County to move to phase 1 as of tomorrow. The governor also announced that she is instituting a requirement to wear facial coverings while in indoor public spaces for certain counties as listed here. These are to be in effect by next week, June 24th, allowing people to have to get the resources in place and the face coverings in place to support their ability to follow through on this requirement. I'm sure much more of that was discussed in a Q&A with the governor today at her press conference. Also, moving ahead, she's announced that that she will be grouping several counties together as regional units for future reopening decisions. So this will now loop the Tri-County area together, Multnomah, Washington County, Clackamas counties for future reopening decisions. And due to that, all 3 counties together will remain in phase 1 for at least 21 days after tomorrow, which is the first moving into phase 1 date for Multnomah County. In addition, Marion and Polk counties will likewise be considered as a regional unit for reopening decisions. If you missed the governor's press conference, surely that will be available online, and we invite you to take a look at that to hear more of the answers she provided to questions asked on these announcements. I also would invite you to visit the Reopening Oregon page, both on our website that has more information on the public health indicators we're tracking, as well as more information on where each county is at each phase. They were not updated as of this morning fully to the announcement, which is why I didn't provide some of them here, but you can keep an eye on those. Dr. Jean?
Yeah, I just wanted to add that as of today, I noticed that the reopening criteria is no longer at the top of the page here. So you just have to scroll down to the governor's orders and OHA guidance section, and that's where you can find the reopening information. But the dashboard is still at the top.
Great. All right, just a brief note on this, and then we're going to move on to Dr. Jean and doing a deeper dive on considering test results. So you might have heard that on earlier this month on June 9th, Governor Brown announced that Oregon will be implementing a comprehensive coronavirus testing plan in long-term care facilities. This is based on her strong focus to help and protect the residents and staff of long-term care facilities, recognizing the significant impact that coronavirus has had in these settings, both in Oregon and nationwide. You can read more about Governor Brown's direction to the Oregon Health Authority to create this long-term facility testing plan in her the press information that you can see here linked on this or on this webinar slide. In addition, subsequent to that, the Oregon Health Authority did finalize and post a long-term care facility testing plan in coordination with the Department of Human Services as part of our COVID response unit. And you can see just a couple of the objectives I listed here for this testing plan. That includes that by September 30th, the plan is focused on ensuring that all residents and staff at all 685 nursing, residential care, and assisted living facilities licensed by DHS will be offered testing for COVID-19 at least once during that time period. And then furthermore, within 30 days of completing that baseline testing, that the state will initiate ongoing testing strategy in coordination with long-term care facilities, with mandatory testing of a quarter of the long-term care facility staff every 7 days, such that all staff will be tested once a month. I didn't have direct involvement in this plan, so I invite you to visit that further plan on our website. I will just tell you that there are some significant assumptions built into that plan that are worth calling out, and it certainly first and foremost assumes that we are able to address the ongoing testing supply needs to be able to facilitate this. As you know, that's been certainly improving as you've seen our testing capacity increase, but still certainly challenges ongoing with supplies and testing that have popped up periodically. And as we continue to respond to large outbreaks across the state and other priority testing, we're going to need to keep an eye on all of that to be able to follow through on this plan as well. So please take a closer look at that testing plan, and we'll keep you updated as that moves along as well. All right, I am going to stop talking at you and pass this off to Dr. Tom, and we'll be keeping a close eye on your questions that we'll come back to as Dr. Jean gets started. Sorry.
Yeah, so just a little preface here about test results. You know, we have testing guidance for clinicians, and our most recent update had expanded some of the recommendations for testing, including asymptomatic people. And we've heard some concerns from some of the health systems about the guidelines and what's really recommended, and should anybody in a given racial or ethnic group, for example, be tested even without symptoms. It's a really difficult question. And so we're working to clarify that right now. And so what I'm going to talk about now in terms of test characteristics and sensitivity and interpreting results, I think is especially an issue for testing patients who don't have symptoms, as you'll see. So, just as a reminder, sensitivity and specificity are some of the basic test characteristics that we look at. Sensitivity is really the true positive rate. So it's the proportion of all people with disease who have a positive test result. Another way of looking at that is the true positives divided by the true positives plus the false negatives. The specificity is the true negative rate. So the proportion of people without disease who have a negative test result. So that would be true negatives divided by true negatives plus false positives. And I just wanted to also, as an aside, say that these are, on their face, pretty simple terms. But when you get into like thinking about, these decisions and thinking through these for any given scenario, it can get pretty confusing pretty quick. And even though I've had a lot of epidemiology training, I still find myself getting confused and having to go back and think. So don't worry if they kind of are confusing to you. So one nice thing that you can do with sensitivity and specificity is you can calculate likelihood ratios, and you can look at the pretest probability of disease, which has to do with the disease prevalence, and you can actually multiply that pretest probability by a likelihood ratio to get the post-test probability. And that can be very useful when you have a patient in front of you and you're trying to make decisions about whether to test and what the test results might mean. Now, there are calculators available that kind of avoid some of the math involved. And there's a pretty good one at this link here, and I'll show some output from that a little bit later. So one of our questions has been, what is the sensitivity of the tests we're using for COVID-19? And some of the initial studies out of China suggested that it might be around 70%, and that's kind of the number we've been citing. There was a review back in May from Johns Hopkins based on 7 studies. With a total of over 1,300 respiratory samples, upper respiratory samples using PCR, to look at the false negative rates, in other words, the sensitivity of PCR tests. So it's worth a read. And what I would highlight here is they've calculated the probability of a false negative result in an infected person. And actually, this is a mistake I didn't fix here. That what the percentages in blue here are the sensitivity, and the red is the false negative rate. And this is based on day after exposure, the date after exposure. So you can see that day 1 after exposure, so a full 24 hours after exposure in general, there's going to be 100% false negative rate. So even though that person's infected, the PCR test will not pick it up. And when you get up to the day before symptom onset, typical symptom onset is about day 5 after exposure. The day before that, day 4, has only a 33% sensitivity for finding the virus, even though that person's infected. On the day of onset, it rises to 62%, and the peak of sensitivity is day 3 after symptom onset, which is day 8 from exposure in general, and that's 80% sensitivity. So even at the peak there, you still have a 20% false negative rate. So I think it's really important to keep this in mind when you're making testing decisions and when you're also interpreting results. Now, days 1 through 4 here with those low sensitivities, that's all, those would be people considered pre-symptomatic, which is a little bit different from somebody who may be truly asymptomatic and infected. We really don't have much good data on asymptomatic testing and the sensitivity. And the problem is, how do you compare it? If somebody doesn't have any symptoms ever, and you test them and they test negative, how do you know that's a false negative or a true negative? And so really the only way to compare would be to do repeated tests and then compare the first test or one test against the repeated tests, or to do something else, perhaps with serology or some other way to determine it, some other gold standard, maybe viral culture. There's lots of problems and challenges with trying to determine that. So that is a caveat about asymptomatic testing, which is really a hugely complicated question. Okay, next slide. So we're going to go through what I mentioned about kind of the pre-test and post-test probability. So I think the general public in general tends to think of a test as kind of an absolute thing. So you want to know whether you have a disease, and you get a test, and the test tells you. But as we know, tests are not perfect. There's really no perfect tests, and even a test that's thought to be very good has some false positives and false negatives. And the COVID test, as I highlighted, may not even have that great sensitivity. So this is just showing on the left here, if you start with a pre-test probability, and that's generally going to be based on the disease prevalence, as well as the particular characteristics of your patient, their risk factors. What does the test result do in terms of your post-test probability? So if we assume a 5% disease prevalence, and you get a negative test, assuming a sensitivity of 70% and a specificity of 95%, which is kind of a very rough ballpark for a PCR test, the post-test probability after the negative test in somebody from that population is 1.6%. So you can see that negative test did change the probability of disease quite a bit, and so it's a useful test. Now, what if you get a positive test in that person? Their post-test probability is actually only 42%. Really not that great from what you might expect. And that's based, again, on the pre-test probability and the characteristics of the test. Now, if somebody in a population that has a 5% prevalence comes to you with clear symptoms and say they've had contact with somebody who has tested positive, that would increase your pre-test probability. And the pre-test probability is really an estimate. So you could say maybe that person now in front of you has what you would estimate to be a 50% probability of actually having COVID. And with this particular test, if they come back positive, you now have a 93% post-test probability. So you can see that's really pretty more conclusive. And then a negative result would only bring you down to about 24%. So there's a lot of math involved. And again, the calculator is pretty good at helping with this. But I think for those of you who are inclined, I think this can be a really helpful way to help with decision making. And I think we'll continue to try to explain this, because I think explaining this kind of concept in different ways helps different people to understand it.
Dr. Dean, before we move on, a question has come up, I think probably particularly due with this slide. These sensitivities that were shown in this review, the studies that were looked at, they include nasal pharyngeal swabs, nasal swabs, oral swabs, and is there a specific commercial test that was used?
That's a good question. So they looked at studies that looked at different upper respiratory specimens, but I believe all these numbers are from NP swabs. There was no restriction based on the test used. So I think they used many different manufacturers' PCR tests. So it's kind of a good overall summary. Okay, so there's a website linked to the bottom here that I mentioned. This is just one of these calculators you can find to estimate based on sensitivity, specificity, and the pretest probability. Number one, what is your post-test probability? And number two, what are your false positive or false negative rates? And it's nice because it shows it in a simple way with graphics. So it can help you understand how that test result really affects your decision making and the post-test probability. So here's an example with a 5%, say a 5% disease prevalence, and that test sensitivity of 70% and a specificity of 95%. For every 100 people who get a positive test result from that test, only 42 are true positives. So you have a 58% false positive rate on that test. And that's because the prevalence is low, the probability before the test was low, and the specificity is not super high. So in the next slide, I'm highlighting what's changing here. If we increase the test specificity to 99%, which may not seem like a big difference from 95%, but it actually makes a huge difference here. We've now gone to only a 21%. We've gone from a 58% false positive rate to a 21% false positive rate just by having that much better test. So I think that highlights how these test parameters that seemingly may not make much difference really can make a difference in certain situations. And then if we go to the next slide, we can see conversely, looking at changing the sensitivity of a test. And what I've done here is I've assumed a much higher pretest probability. So again, say somebody who you're either testing from, say a nursing home that has an outbreak, and so you've just got a much higher prevalence and pretest probability, or say a patient who has symptoms and a clear exposure history. So with a higher pretest probability, the same test, 70% sensitivity, 95% specificity, will actually give you a 24% false negative rate. So for every 100 people who test negative, 24 of them actually do have the disease, and they're coming up as false negative. And this is a question of the sensitivity in this case. It's that low sensitivity, 70%. And the next slide, if we increase the sensitivity to 90%, that 24% false negative drops to 10% false negative. So clearly this indicates the importance of having good tests, but also how, given the tests that we have and the disease prevalence and all the risk factors that you're taking into consideration, what do you do with those results? So I think I would encourage you all to kind of play around with that calculator and think about this and come up with additional questions, because certainly I've tried to walk you through this, but I think there's still a lot of things that can be confusing about it, or a lot of questions that might come up. So we'll try to keep explaining some of those things. But again, as people are doing more and more testing around the country, I think it's really important for providers to understand this, so that you can explain to patients, number one, why in some cases you may not recommend a test, and number two, some of the uncertainties about the test results. And then additionally, there are concerns if somebody who doesn't have symptoms tests positive, they're going to be, if it's a false positive, which it very well could be, there's consequences. People may be quarantined or isolated. They may not be able to go back to work. So there's a lot of concerns.
Thanks. Thanks, Dr. Jean. We're getting a variety of questions. I'm going to try to pause us here on testing to see if we can answer some of them. I'm going to go back a little ways first. This is a little bit more reflective of the case counts we're reporting on in our epi curve. And I just want us to clarify again, we've mentioned this before, but the question is, are we reporting on testing results from antibody testing in any of our reporting on case counts or epi curve?
Good question. Nope, we're not doing any. We are tracking antibody results, both positive and negative, but they are not considered a diagnostic test for COVID-19. So we are not including those in any of our case counts. But we do think antibody testing is important for surveillance, to get a sense for the disease. So we are working on kind of surveillance studies. But if we were to just look at those numbers coming in, it's not a random sample, so it wouldn't be very informative to tell us about the prevalence. And again, they're not diagnostic, because there's no way when that person might have been infected and contagious.
Great. A couple other questions that I'm seeing here. Curious about testing and correction systems. This relates a little bit to the testing question, of course, but also to the outbreaks and risks to particular places where people are living closely together or working closely together. I can just comment briefly. I don't, and I'll see if my colleagues know more. Department of Corrections has been heavily engaged in the COVID-19 response. As we've reported before, the this inquiry is accurate in that this is a high risk area, and there have been quite a number of positive cases in correction settings, and a lot of work as part of our state's emergency response to address those and to consider approaches to testing in those areas. I'm not directly involved, and I don't have more detail for you on that, other than knowing and having heard reports intermittently on the work that's being done. So it's a substantial body of work addressing this, but I don't know the details about how testing is being approached. So I'm looking to my colleagues in the room if you have any more detail.
Not recent updates, but we have been working closely with Department of Corrections to help them when they have had outbreaks, and to improve their testing, making sure that adults in custody and youth in custody are getting the testing they need and getting results in a timely fashion, because in many cases, in some cases, they could be tested before release, and then the result isn't back yet, and then they're released in the community, which could be a problem especially if they come back with a positive result. So we're working to improve those and make sure that we're getting timely testing as needed.
A couple other questions. I know there's a lot. We'll try to get through a few more and then make sure we share some of the answers that you had already sent us in just a minute. There's a question about the use of testing in asymptomatic individuals prior to elective procedures. And as an example, we actually do answer this question in our frequently asked question on elective procedures. We know that this is happening a lot across our state, and for sure I'm aware of this in our metro area. This has been a hot topic, and it's still an ongoing discussion. Some of the orientation around pre-procedure testing is based on literature that I haven't looked at lately, although I've heard spoken of has been increasing about the risk factors for someone who might be asymptomatic or pre-symptomatic with COVID and goes through an elective procedure and has a worse outcome. So that is certainly part of what I understand of the motivation for some of the testing that's gone on in pre-procedure testing. But certainly as we're thinking about the limitations of testing, as well as we've been describing here, that needs to be a considered factor in all of this. And in our FAQ at this point, we at least point out some of those considerations in how this data is used. I think right now, as we're continuing to look at the evolving literature around understanding the the parameters of our new testing that continues to come on board, or what we're learning about our current assays being used for PCR testing, we're continuing to bring that information to bear on understanding how to consider results, and certainly knowing the limitations of those results. So I don't have a definitive answer. There's multiple things being considered. And certainly I've also been aware that the workforce, there's definitely been a push for workforce to want to have testing before they're doing procedures, again, for some further information about any risk, both for themselves as well as the patients. And again, all of this needs to be considered in light of the limitations of studies that was just outlined. So more information to come on that. And an important question to continue to look at. I think the one last question we can answer quickly before we move on is who are you recommending to get antibody testing? I'm going to look to my colleagues here if they want to answer that question.
Well, we have some guidance on this in our testing guidance. We have a whole section on serology testing, and we don't make explicit recommendations as to who should get tested for antibodies. We basically list a bunch of caveats and things that providers should keep in mind and patients should keep in mind about antibodies, including the fact that even if you're positive and it's a true positive antibody result, that may not indicate much immunity, because we still don't know the strength or the duration of immunity for COVID-19.
Yeah, and right now the Oregon Health Plan's only recommending that you test people under the age of 21 who you're considering for this multi-system inflammatory disease in children who are hospitalized. All other antibody testing for OHP should only be done as part of a study.
Okay, I realize now that we can access the chat box, we're going to need to plan our time a little differently. I'm going to ask Dr. Smits to go through some of the updates as quickly, but so it's still clear for everybody. If you need to drop off, these slides will be posted online as well as the recording. So please go to our coronavirus page for healthcare providers and you will be able to find all of these posted. I apologize, we're going long, but we'll make sure to get out this information. If you need to leave us, please check back online for the information.
Yeah, so the first study that I wanted to bring to your attention is an early preprint of one arm of the recovery trial. A lot of caveats to this. It's a preprint, not peer-reviewed. We haven't been able to look at the specifics, looking at the different, whether the patients were comparative in the arms, et cetera, et cetera. But the results were so significant that the study team wanted it out into the world so that people could consider it. So the recovery trial is being conducted by Oxford in the National Health System in Great Britain. They have about 11,500 patients who've been hospitalized. They have 7 arms, 6 have different drugs, and 1 is usual care. I believe their hydroxychloroquine arm is actually closed. One of the arms is dexamethasone. So about 2,000 patients received 6 milligrams of dexamethasone for 10 days. And they were compared with 4,300 usual care patients. And this really had a significant reduction in death. For ventilated patients, it reduced death rates by about 1/3. For patients not ventilated but requiring oxygen, it reduced death rates by about 1/5. And there was no benefits for those people who did not require respiratory support, which would kind of make sense in kind of what we're thinking about with dexamethasone reducing the immune system over response that might be causing some of these patients to have the cytokine storm or whatever might be going on. So really, really interesting, important findings, and we'll be really anxious to see the final print of this. The only other thing I really wanted to bring to your attention is the FDA just a couple days ago put out a new drug interaction warning. If you are still using chloroquine or hydroxychloroquine, it can interfere with remdesivir. So they're not recommending that you co-administer those drugs.
I would also note here, we should have included here a notification that the FDA also removed the emergency use authorization of chloroquine and hydroxychloroquine for the treatment of COVID-19. So sorry, that should have been an important one here. I think that news about the potential risks outweighing any potential benefits has been pretty broadly disseminated, but please note that the emergency use authorization for treatment of COVID-19 with chloroquine or hydroxychloroquine has been removed by the FDA. We have likewise updated our rules under our Board of Pharmacy here in the state to match that. But this interaction is nonetheless important. Other people may be taking these medications for other reasons.
Particularly if they have rheumatoid arthritis or some other diseases where these are indicated drugs.
Great.
So this actually these are the answers to your questions from a week ago. This actually isn't a question, I just wanted to bring it to your attention. If you have uninsured patients, I just really want you to be aware that uninsured or underinsured patients can, as part of multiple different acts that have been passed by Congress recently, that you can get reimbursed for testing or treatment. So please, if you have anyone that is uninsured, you can go ahead and test them. You have to go to the website that's there and they'll reimburse you at Medicare rates. And then going on to the clinical care questions, one of them was basically, we know that there's a lot of conditions that predispose you to more severe disease. If that underlying condition is controlled, is it less of a risk factor? It's a great question. We don't have any data on that at all. But we do know that those hypertension, diabetes, et cetera, are risk factors. I would still try to get your patients under good control because it's good clinical care and will help them in many other ways, and hopefully will also help them with the severity of COVID. Do we know anything about the impact of ACE and ARBs on disease? We've reviewed this in a previous webinar, but it's always good to bring up again. A rapid review by the Oxford Center for Evidence-Based Medicine found no association between these drugs and severity of disease, and all of the major American Heart Association, all the major clinical groups are still recommending that you continue your patient on their ACE or ARB as they are currently on it. There's a question about cholesterol levels and whether this affects the severity of COVID. Cholesterol by itself has not been identified as a risk factor for severity of COVID disease, but we all know that high cholesterol is associated with hypertension, heart disease, diabetes, and a lot of other known risk factors. So even though it's not been identified, eventually we may piece it out as a piece of that or not. But again, controlling your patient's high cholesterol has many benefits beyond COVID control. Then there was a question for how long are we finding symptoms persisting? When you have a patient who's positive, what should you tell them about how long it's going to take to recover? According to the World Health Organization, patients with mild disease pretty much are recovering within about 2 weeks. But if you have more severe disease, it can take 3 to 6 weeks for symptom resolution. And of course, if you've been hospitalized, intubated, other, really, really severe disease, it can take months to completely recover.
And I'll just alert you to remind you on our weekly update that we publish every Wednesday, we include information about recovery of organ cases. It can give you a little bit more insight into organ-specific cases on their time to recovery. So take a look at that as well.
Yep. There was a question about what's the survival rate on vents. I probably should have updated this a little bit. It's 66 to 86% of patients died who were on ventilators based on 2 case series. Those were series from Great Britain and China. There's actually been several other case series from Seattle and from New York City that have been published that are in the same range. So unfortunately, this group has very poor outcomes. And then there was questions about what kind of sequelae are there for people who've had severe COVID infections. I think this is a really, really important question. It hasn't really been studied because we haven't had a lot of survivors who've had long-term outcomes yet. We'll definitely keep an eye on the literature for that. And that's going to be a really important question about what kind of services or rehabilitation or other things that you might need to keep in mind for your patients. And then the last set, there's a bunch of information going around in the sort of lay literature, the newspapers, et cetera, about blood types. That there might be more severe disease in blood type A versus blood type O. These are all based on preprint, non-peer-reviewed studies. It hasn't been seen in the US, interestingly. And in fact, African Americans in the US are more likely to have type O blood, and they have actually had a disproportionately higher COVID infection rate, probably for many, many reasons. So my takeaway from all of this is that it's probably not the blood type, but it might be other immune-related genes that are kind of co-inherited with the blood type that might be involved in this sort of severe immune reaction to the virus. So if your patient's asking for their blood type because they're worried about this, I don't think that's really a really useful thing to do. And then there was a question for how can we safely restart office spirometry? And I think the short answer is you can't do this safely. The CDC considers spirometry, just like nebulizer therapy, to be a high-risk aerosolizing generating exposure. So if you want to do this in your office, your staff has to have very, aerosolized protective gear, N95 masks. I forgot eye protection, but they need that, gowns, gloves. And at this point, I would recommend probably waiting on spirometry. Nebulizer therapy we know might help somebody who might be able to, has a disease symptomatic outbreak that you could help, but I don't think we really need to do spirometry at this point. But if you do, make sure you protect your staff.
Thank you, and thanks. Oh, sorry. One more set.
There's a lot more questions. So there are some questions about target for oxygen levels in COVID patients. The World Health Organization is recommending that you target at or above 90%. Although there has been lots of case reports of people walking around with oxygen saturations of 70% who are doing fine. But that, there's a kind of a general target is greater than 90. And then this is an important question for a lot of patients asking about this. Should we have pulse should we get a home pulse ox? Should you have pulse oxes to screen your asymptomatic patients? The American Lung Association has basically said this does not play any role in COVID screening. You need to look at other symptoms, fever, shortness of breath, etc. And a normal pulse ox reading does not rule out disease at all, so it can provide a false sense of security. And then there was another question about how valid is temperature checks as a screening tool. And just to remind you, fever is just one symptom. Many patients with COVID don't report fever, or they may not at the point that they're presenting to your office or to wherever they're being screened. So OHA is recommending screening with many things: questionnaires, asking about symptoms, checking temperatures, etc. Not to rely on just the temperature. And we also have some concerns about some of the non-oral thermometers as not being the most reliable measurement tools.
All right, with that whirlwind, we are gonna pause now and let you get back to your day. Again, we will post this. Sorry for going long. Appreciate all the questions that you've sent us. The ones that we didn't get, we will collect and try to incorporate them over the next 1 to 2 weeks in both potentially the Project Echo session next Thursday and then the week after our next OHA webinar. So again, just an updated slide here on our new schedule that we started earlier this month. So we hope you can join us next Thursday for the Project Echo, and then again, ongoing Thursdays, going back and forth between the two. So thank you for your time, your questions, all the work that you're doing, and we will join you again in a week. Thanks, bye.